I have indeed the privilege of welcoming and turning back to the Health Provision, Preparedness and Resilience session for public health emergencies. Effective healthcare provision relates on infrastructure, trained human resources for health, access to medicines, diagnostics and communications. And to give the keynote of this session, we are pleased to have with us Mr. Manoj Jhalani, Director of Health Systems Development for the World Health Organization, Southeast Asia Regional Office in New Delhi. Manojji, it's our privilege to bring you back here from last year, but I wish you could have been here in person. Mr. Jhalani is a distinguished member of the Indian Administrative Service, and his extensive experience includes serving Joint Secretary Policy and Mission Director for the National Health Mission in the Ministry of Health and Family Welfare, Government of India. His deep love for health and administration has not gone away and has been brought forward into what he does at the WHO. With a background of planning and implementation in social sectors and policies in Madhya Pradesh, India, he received several accolades, including the UNITAF Award for addressing the NCD challenge in India. Privileged to have you here and missing you in person very much. Thank you, Manojji. Thank you for being here. All yours.
Maji, I hope you can hear me loud and clear.
Yes, very much. And see you too.
Thank you so much. Thanks a lot.
Yes.
I indeed wish I was there in person, and indeed it's my great honor to address this August gathering of Global Learning Collaborative for Health Systems Resilience, Annual Conclave 2024. And so first of all, thanks to Dr. Reddy Uma and Nexus Health International team for inviting me to this event, and I wholeheartedly wish this collaborative for health systems resilience all success in this annual conclave and its future journey ahead. The collaborative's vision, purpose, and mission are very well aligned with the WHO's perspective and the learning following COVID-19. I notice from panel that you have an excellent moderator and panel, and we've been working with this panel and moderator also through our regional PHC forum. Our session is titled Ensuring Preparedness and Building Resilience of Healthcare Provision During Public Health Emergencies, and I've been requested to focus my address around the topic of role of primary healthcare in building health systems resilience. I'll try to keep this in mind in my presentation, which has largely been prepared by my friend and colleague, Ibadat, and I'll also touch upon what the WHO is doing to advance resilient health systems. When I was thinking about resilience, and most of the time, you think of COVID pandemic and then health systems resilience, but when you look around globally, there are simultaneous turbulences happening. You have the economic turbulence, you have the geopolitical turbulence, you have the epidemiological, demographic turbulence, you have climate change and environmental degradation, you have technological disruptions now, AI and LLPs and supply chain disruptions and inequitable global order. So, we have to think in terms of resilience amidst all such challenges and disruptions. Now, of course, I don't need to define what WHO thinks of resilient health systems as the ability to prevent, prepare, and for detect, adapt to, and respond to, and recover from public health threats, and ensure continuing of existing healthcare and maintain essential and routine health services in all contexts, including in fragile conflict and violence settings. So that's the broad background. Let's move next slide, please. So this is the broad overview of my presentation, where I touch upon the socioeconomic impact. I'll touch on COVID-19 pandemic, not many years back, and then learning from what has been the learning from COVID-19, and the regional office, WHO's complementary efforts in health security, and UHC, we feel that these are just the two sides of the same coin. And with our region as an example on how the UHC and health security are complementary goals. And then PHC really is the most efficient and equitable approach to achieve the goals of UHC and health security. I'm using the word PHC approach. I'm slightly distinguishing it from primary care, but this is the mechanism of the approach to ensure integrated essential health services, and this integration is very wide. Integration with the essential health, public health functions, integration across levels of care, integration across life course, integration across disease conditions, etc. And also in our PHC approach, we talk of three pillars. So one is integrated essential services with integration of public health function. The second one is in terms community empowerment and community trust. And the third one is around multisectoral action. So these are all very critical to advance both UHC and health security, and also for advancing health and well-being. We have these triple billions in the WHO in terms of prevent, protect, and provide. And so it also advances better health and well-being, not only in terms of health promotion and primary and secondary prevention. And now with growing burden of NCDs, you think in terms of lifelong chronic care. So you really need to strengthen primary health care. And we realize that the patients, the NCD patients, were the worst hit during the COVID pandemic. So really, we need to have our capacities enhanced at the primary health care level to manage these, to be able to also better prevent and respond to any public health emergencies like COVID. And lastly, we are in this learning collaborative meeting and gathering, and the importance of learning health system, where you have a culture, a systematic approach to improving a health system's performance through a culture of continuous learning, continuous innovation, continuous improvement, continuing adaptation, looking at the evidence, analyzing evidence, and applying the learning, and then improving policies and decision making. Next, please. Now, just quick thing on capture of socio-economic cost of just the COVID pandemic. And what we noticed, so the first thing was that in terms of our estimation of excess deaths, excess mortality. Now, excess mortality is something like, based on the historical trend, what would have been the number of deaths in a year globally, and compared to that, what were the actual number of deaths that happened globally. So it captures both the direct and indirect impact of COVID. So there were disruption of essential health services globally, and as a result of which also there was enhanced mortality. And globally, there was 14.83 million excess deaths, and our region, Southeast Asia region, was one of the worst affected regions globally in terms of excess deaths. With the help of countries, we conducted pulse surveys to look at the continuation of essential health services, and what we found that almost 90% of the countries did report disruption of essential health services to one or more of essential health services. So there was a large-scale impact, in terms of that's the lack of resilience, that our essential health services were disrupted in 90% of the countries. Not all services were impacted, but depending on, some countries, more than 3/4 of the services were impacted, while in some countries only about 10-20% of the services were impacted. And but in our region, almost 8 out of 9 countries reported disruption of essential health services. In terms of the economic loss, there was almost estimated $12 trillion US dollars loss, and 135 million plus people were pushed into poverty. So not only in terms of contraction of economy, but that its impact was felt more by the poor And majority of these additional poor people were in the South Asia region. Now, this South Asia region is the World Bank South Asia region, not the WHO Southeast Asia region. But largely there is an overlap between the World Bank South Asia and the WHO Southeast Asia region. And a large proportion of the people who were pushed into poverty were in our region. In terms of education, I looked at data and the World Bank study. It said that the number of 10-year-old children in South Asia who cannot read simple text grew from close to about 60% to close to about 80%. And we all know how important education is for lifelong learning and lifelong health and well-being. So big impact of COVID on economies, on education, and again, our region is also prone to the climate threats. And what we realize in the last 2 decades, more than half of all South Asians have been affected by at least one natural disaster, such as flooding or drought or cyclone. And based on these trends, the losses in the region will average around $160 billion annually by 2030. So this is the World Bank estimation. So what we notice is that all these public health emergencies, it's not only the health impact, but also a significant economic and impact, and also on the socio-economic indicators. Next, please. Now, escalating risk. I mean, I talked of UHC in turbulent times. So there's geopolitical turbulence, there's economic turbulence, technological, with all the AI, with huge potential, but also need for ethical and responsible use of AI, which could really also pose significant threats. And then, you have other disruptions. The intensity and frequency of extreme novel pathogens has been increasing on account of environmental degradation, rapid urbanization, international travel and trade, and also humanitarian crises fueling cross-border transmission. So we notice because of these novel pathogens, and the frequency and intensity has been increasing in the last 2 decades. Again, climate events are also increasing both in frequency and in scale, with its heat waves, cyclones, droughts, floods. And as I said, more than half of South Asian people were affected by one or more of these disasters in the last 2 decades. And in terms of economic crisis, so what we notice, including in our region, in Sri Lanka, and of course, not in the Southeast Asia region, but in the South Asia is also Pakistan, where there are major issues around debt stress and inflation. And within that, we have to make sure that our investments in health remain protected, and we would also even want to enhance investments in health to build back better. Of course, so these are, of course, concerns, and this economic crisis does pose a challenge, but we also notice and learn that even in our region, even in the major reform in Thailand happened at a time of economic crisis. So sometimes great things can happen in crisis. They also offer us opportunities to undertake transformative reform. So when countries are really looking for cutting costs, looking at enhancing efficiencies, it's a good time for them to move in the direction of PHC-oriented health systems that are far more efficient than the hospital-oriented health system. So this could be an opportunity for us for those practitioners to influence policies, so that it helps in terms of countries building back better, more efficient health systems, which are advancing UHC and health security at the same time. Next, please. Now, what the learning from COVID was that I mean, even in developed countries, the gaps were noticed. They couldn't respond to the surge needs, etc. But what we noticed, and we undertook a universal health preparedness review. Thailand volunteered for this UHPR, and so the international team from WHO and other countries visited Thailand and looked at their health preparedness. And they conducted it in 2022. And this is more like a tool to promote a systematic country-led review by health and non-health actors, and utilizing the lessons learned from the past health emergencies. And what this study brought out, they brought out specific areas that needed to be strengthened to be better prepared to respond to future public health threats, including pandemics. But what it brought out was that the previous investments in primary health care were fundamental to effective COVID response in Thailand. So, and it similarly showed that in urban PHC, there was not such a good response because they didn't have existing platforms for community and multisectoral engagement. So the response in the rural areas was far superior to the urban areas because urban PHC was weak. And we noticed that in other countries of our region, including Bhutan and Sri Lanka, etc., who are relatively better equipped to respond to pandemic because of robust primary health care. We also noticed that wherever it required, the learning was that you needed a platform for whole of government and whole of society action. The countries innovated approaches for community and private sector engagement, and wherever there were existing platforms, they could be leveraged and they worked better. They found ways to optimizing health workforce, the trainees, the retirees, and task shifting, etc. There was also leapfrogging in use of digital technologies in terms of use of telemedicine, teleeducation, etc. In terms of also scale of manufacturing and distribution, whether it is COVID vaccines or other medical products. So we noticed fairly agile and evidence-informed health policies across countries in our region. And one thing that came out very strongly was the cost of inaction is far greater than the cost of action. And the WHO Council on Economics of Health for All estimated that addressing the gaps in pandemic preparedness would just be being 1% of the losses on account of inaction. Okay, next please. Now, what we noticed is that there has been a very robust political commitment. So, with all that crisis, one thing that came out was that all countries were very keen to build back better, and they realized that this building back better had to be on PHC foundation. So, I recall in September 2021, we had the Southeast Asia region ministers of state, and in the ministerial roundtable declaration, they said that this opportunity to build back better, and they said it's a once in a century opportunity to enable PHC oriented transformation. So this is the political clarion call. Then you have they asked us to come out with a regional strategy for primary healthcare, and we came out with a regional strategy for primary healthcare 2022-30, which is based on building on the learning from COVID-19 plus global learning. And it elaborates those 7 values in 12 strategic interrelated actions. And it does provide how part of it. And we also created a regional PHC forum at the request of the ministers from all countries to create a regional PHC forum under the leadership of member states, but involving all the partners, including development partners, knowledge partners, implementation partners, and creating a mechanism to sharing and learning and facilitating the adaptation and implementation. We had the UNGA General Assembly political declaration on the UHC, where the Thailand country of our region was the co-lead. We also had the G20 summit in New Delhi, and India was the chair, and then it called for time-bound commitments to strengthening primary healthcare And this year, in their ministerial roundtable of health ministers, they adopted strengthening primary health care as key element for universal health coverage. So there is this big political momentum now. The next, please. It's a challenge, and this is about our own PHC strategy, regional PHC strategy, the values. There are 7 values, but one key, besides the values of universality, equity, solidarity, accountability, people-centeredness, resilience, and adaptiveness and evidence-driven action are the key values that the strong PHC momentum across countries. I mean, you can, so you have in all countries of our region, Bangladesh, Bhutan, DPRK, India, with all its on primary health care in Maldives and Myanmar. Where our learning collaborators become extremely important. Next, please. I talked about the values. I also talked about countries trying to move from primary care, countries getting more interested in integration of service delivery and also integration of essential public health functions. At in the primary care platform. I mean, whether it's contact tracing or whether it's surveillance or risk communication, engaging with the communities. So, and again, the PHC strategy focused on learning health system, creating a culture of looking at evidence, analyzing evidence, applying the evidence, and continuously learning and improving. We created the CRPHC forum. I'm very grateful. Dr. Reddy and team have been one of those founding partners for this regional CHC forum, which again is trying to capture the operational learning and synergizing support and driving action in the countries. Similarly, on the health security side, we came out with a regional strategic roadmap for health security in our region. We after the COVID pandemic, every time after public health emergency, we have detailed consultations with the experts and member states and try to build on the learning. And then we came out with a regional strategic roadmap for health security, which talked of enhancing the what we are looking at is, involving the heads of the governments of Southeast Asia region. This is an important proposal which is under consideration of the member states of the region. We will know its outcome after our WHO discussions and then during the next regional committee. But the objective is to create for the Southeast Asia region WHO, a regional health emergency council of heads of the government, which will then ensure the highest level political commitment to strengthen health emergency preparedness and response and ensure health system resilience. And as I said, these are UHC and health system, health security are two sides of the same coin. So what we recognized during COVID response was that it's not the health ministries that can drive this. It is really the head of the governments which can really bring about the whole of government approach, and that will really provide that resilience in health security. And that's why we need to have a regional health emergency council of heads of the governments. Next, please. Now, we had, as I mentioned in my previous slide, we had this Ministers of Health roundtable in Delhi last year, and they came out with the PHC, the key element for UHC, and they identified these 11 areas action. So priority to primary healthcare in the health budget, strengthening accountability, capacities, and governance, institutionalizing social participation, integrating across life cycle, essential public health functions like levels of care, disease conditions, multidisciplinary PHC teams, supply chain logistics management, strengthen digital health ecosystem, addressing PHC in urban and peri-urban areas, quality and patient safety, very critical area, PHC monitoring systems, monitoring the performance of primary health care and monitoring the PHC orientation of health systems, and lastly, the knowledge management, not only at the regional global level, but also at the national and subnational level. Next, please. So these were, the WHO came out with a white paper, and they came out position paper on building health system resilience towards UHC and health security during COVID-19 and beyond. And then it provided the 7 policy recommendations to reinforce the urgent need for renewed and heightened national and global commitment to make countries better prepared and health systems resilient against all forms of public health threats for sustained progress both towards UHC and health security. I can quote the DG WHO here: we cannot build a safer world from top down, we must build from the ground up. Preparing for, preventing, detecting, and responding rapidly to epidemics starts with strong primary health care and public health systems, skilled health workers, and communities empowered and enabled to take charge of their own health. That must be the focus of our attention and our investment. So this is what WHO said during the launch. And these are the 7 policy recommendations that you see on the screen: leveraging the current response to strengthen both preparedness in health systems, investing in essential public health functions, building a strong primary health care foundation, also investing in institutionalized mechanisms for whole of society engagement. So this is one of the challenges which was recognized during our COVID response. And then creating and promoting enabling environments for research, innovation, learning. That's what we're talking about here today. Increasing domestic global investment and addressing pre-existing inequities. We see that the impact of pandemics is much more on the marginalized and vulnerable populations. Next, please. So, towards the last slide, my presentation. So PHC approach is critical not only for universal health coverage, but also for health security and also for promoting good health. This is efficient and also equitable. So this is what we need to advance, particularly in the constrained economies, and take these constraints as an opportunity and try to bring about the reforms and PHC orientation of health system. The second thing is around integration, and integration, which is about integrating essential public health functions. We realize that one of the our primary care systems and PHC systems in the countries didn't have integration of essential public health functions, which created difficulties in responding for the pandemic. And also the quality is not just the coverage, but quality coverage, which is critical to really create impact, both in terms of efficiency gains, improving our health, and quality is a major challenge for primary health care. And lastly, the huge potential of digital health. So these would be critical as we move forward for advancing UHC and health security, leveraging unprecedented momentum, using crisis and opportunity to head our key reforms for PHC approach. Learning collaboration. So we really need to create institutions and global knowledge management mechanisms for sharing and applying learning for continuous improvement would be critical. And lastly, and we feel extremely critical, is that collaboration for the pandemic treaty will be critical for advancing a more secure, health secure world. Thank you so much. And over to you, Ma. I'm sorry if I took more time. Thank you.
Thank you so much, Mr. Manoj Jhalani. We'll now have a panel discussion on this very important topic. And I would like to introduce our moderator, Girish Bomakanti, the Director of Strategic Growth for Access Health International, as well as to invite some of our following panelists who've joined us physically in this ballroom. Dr. Chawisa, Head of Secretariat, the Asia Pacific Action Alliance on Human Resources for Health. She's completed her residency in the Field Epidemiology Training Program. Secondly, Ibu Dia Satyani Saminasi, the founder and CEO of the Center for Indonesia's Strategic Development Initiatives. She's also a development practitioner and public health advocate. Thirdly, Dr. GSP Ranasinghe, the Director, Primary Health Services of the Ministry of Health in Sri Lanka. He is a public health expert focusing on public health management, molecular medicine, and health systems development. Dr. Sanjay Sarin, Vice President of FIND. He serves as on the Global Fund's COVID-19 Technical Advisory Group and is a member of India's AMR Innovation Hub. And last but not least, we have Dr. Vikash Keshri, Executive Director of the State Health Resource Center in Chhattisgarh, India. So Girish, over to you, please.
Thank you, Tim. Let me check. Vikas, you able to hear us?
Yes, loud and clear. Thank
Yes, Mr. Jhalani, you want to have a word? Yeah, okay. Thank you so much. First of all, welcome to all the panelists to this session on healthcare provision preparedness and resilience for public health emergency. Before we head on, I think thanks to Mr. Jhalani for your wonderful insights from the WHO CRO Forum and large initiatives which are being undertaken as part of the work specifically to primary healthcare resilience, but also a lot of commitment in terms of building back the better healthcare systems, especially in the healthcare provision, what we're looking at. So looking at, I think in the last day and today's sessions, and looking at some of the key things in terms of today's topic and the session and the panel what we have, the emerging words seen from speakers, right from the keynote address was around how we are actually building the essential public health functions, public health infrastructure, especially in primary care, and resilience. I think these are the common words which we have been used and we are looked at. What we want to do in this session actually is the key takeaways in the discussion from the panel is that what we can go back and do into our work in each of our places, and also from the Global Learning Collaborative, can we take few insights and take it back to work? So when we come back later in the coming year or conclaves, I think there could be more evidence to discuss in some of the things. What we have seen in the, I think yesterday was on the health systems tools. We discussed around some of the health financing tools, which is gone, digital health tools. So similarly today in the healthcare provision, so we have the panel which actually resembles the entire health provision or the service delivery network from human resources, IT, diagnostics, and the service delivery itself. So we have a rich panel today. Without much wastage of time, I would go ahead. So initially, I would probably have the team members for a brief intro, introduce yourself, and then probably we'll get away into the questions. Maybe with Chaisa, we'll start with you.
Hi. Good afternoon, everybody, ladies and gentlemen. First of all, I would like to thank you very much for having me today. So before everything, I would like to introduce myself. As the medical epidemiologist working at a very front line during the COVID-19 pandemic in Thailand, I work alongside with the field epidemiology network TURAF Thailand. They are geographically distributed in the name of CDCU team, or Communicable Disease Control Unit. They act as a surveillance and rapid response team. They all geographically distribute and work closely with village health volunteers throughout Thailand. They really contribute to the sustainable and resilient communities and sustainable outcome in the community of Thailand. Yeah, back in a time, for me, pandemic is really hard. But at the same time, it's also the time that I realized that human resource for health is lies at heart of the health system. So then that's why I joined the AAAH, the Asia Pacific Action Alliance on Human Resource for Health. It's the regional mechanism partnership composed of 22 countries this day. It's the home. 22 countries is home for 1.5% of global health workforce. And it's a very good position to take action or raise some voice and making sure that all of the voice of Asia Pacific have to be heard in the global dialogues. And this is me today. Do you want me to continue something? No. Okay. Okay.
Thank you. It's nice to be back in the conclave and to see familiar faces. Thank you, Dr. Reddy, for inviting CISD again, and we hope we can contribute. I'm Dia Saminarsi, CEO and founder of Center for Indonesia Strategic Development Initiatives, or shortened as CISD. Jack, you mentioned CISD a lot in your panel, and thank you for the very positive note. I would like to present us with the context when we talk about primary healthcare, and Manoj, greetings to you too. Manoj have laid out the primary healthcare and see it or tie it with the resilience context. I would like to present and as a thinking trigger for thinking that perhaps when we talk about resilience, we must focus not only on the communities, resilience of communities, but also when we talk about primary healthcare and see it in a health system context, we also would like to underline that resilience as a world. So pandemic treaty and also the pandemic fund for the financing and other avenues where we can talk about resilience and focus on strengthening the primary healthcare system, but approach it from different angles. Perhaps I would end there and will give the clear example later.
Thank you. Good afternoon, and I would like to thank Dr. Reddy and Uma, and glad to come back to GLC from last year. And I'm Dr. Samantha. I'm the Director Primary Care Services as well as Director Training for the Ministry of Health Sri Lanka. So I'm a consultant in health administration. For 12 years, I was in critical care and A&E as a medical officer, and then I shifted to the medical administration, medical healthcare management. So I have worked in hospitals as directors and also several posts in the Ministry of Health. Currently, I am the Director Primary Care. So I think in my view, the primary care itself can't strengthen. I think integrated services, like integrated levels, will help in primary care strengthening. That's what we are focusing on in Sri Lanka. And also it's a cost-effective and economic model for a country. So I would like to thank all the GLC members, and also nice to meet, nice to see Dr. Jhalani from India, and also Ibadat. Thank you.
Good afternoon, everyone. First of all, my thanks to Dr. Reddy and to Access Health International for inviting me to be a part of this learning collaborative on health system resilience. So as introduced, I'm Sanjay Sareen, and I'm the head of Access at FIND, which is an acronym for Foundation for Innovative New Diagnostics. So we are an international nonprofit. We're headquartered in Geneva in Switzerland and have now offices across India, Vietnam, South Africa, Kenya, and Indonesia, which is the newest kid on the block. As the name suggests, FIND's focus has been and continues to be on the development and implementation of diagnostics. We were established in 2003, essentially as a product development partnership, which meant that our primary focus was around developing diagnostics for diseases of the poor. We now have 8 programs across universal health coverage and global health security. And not only are we actively engaged in working with industry partners and academia around the development of newer diagnostics, but have also been very actively engaged in working with the countries, in enabling them in the implementation of their diagnostic strategies, and more importantly, helping the countries and communities in the adoption, uptake, and usage of these diagnostic technologies, which we have been supporting the development of. From a COVID-19 standpoint, FIND played a very pivotal role in terms of enabling both development and availability of diagnostics. We were the co-leads of the diagnostic pillar under the ACT Accelerator, or the Access to COVID Tools Accelerator. Worked very closely with Global Fund and a range of global health agencies to implement programs across more than 40 countries. It is again a pleasure, and during the course of our discussions today, we'll probably focus on diagnostics, which, despite the fact that it is the first line of defense, continues to be a rather neglected child when it comes to healthcare. Even when we talk about medical countermeasures, it is vaccines, therapeutics, and diagnostics, whereas I think it ideally should be starting with diagnostics. So look forward to the conversation.
Thank you, Sanjay. Over to you, Vikas.
Yeah, thanks, Grace. Thanks, Grace, and good morning, good afternoon, everyone. So sorry to miss this. I was supposed to join in person there, but due to some emergency coming out within the health system here in Chhattisgarh, India, I had to cancel my trip last moment. So apologies for that, but I'm very glad that I can join online, and this is one of the critical learning we generated from the last pandemic. So thanks once again, the GLC4HSR Secretariat Access, for inviting me for this conversation. My name is Vikas Kesri, and I am the Executive Director at the State Health Resource Center. It's an additional think tank or a technical body for supporting the state government in Central Indian state of Chhattisgarh for their health sector reform and to run the community health program. In terms of COVID-19, my experiences with COVID-19 has been a bit different from other panelists here. Probably I was not at the forefront because I was pursuing my PhD then and doing my own research, but as has been very well documented in research and evidence, it had been a very challenging and isolating years for researchers during the COVID time because research was difficult to conduct and isolation from going to field, actually do your research firsthand. The privilege was not there. So it was very isolating. But if I talk from the point of view of my organization, current organization, I think the SHRC, the State Health Resource Center in Chhattisgarh, contributed a lot to the system, to support the system in responding to COVID-19, right from the strength, using the strength of community health workers who work at the grassroots and how they supported in contact tracing, identifying patients and referring them for the appropriate care. So I'll be sharing some of these insight during conversation later. As per me, I am a medical doctor trained in India and then with a master's in community medicine and a PhD in global health from the University of New South Wales. I'm also an adjunct senior lecturer with the University of New South Wales. And I identify myself as a health policy system researcher, and that's me. Thank you.
Yeah, thanks, Vikas. Thanks everybody. What we will do is that we'll have a questions round within the panel right now, and then we may have questions within the audience also as part of this discussion as relevant. We can take that. I think given the discussions what we are having, and this is to Dr. Chevisva, is to really look at the real core point in terms of workforce, is that there's a huge shortage of health workers or the medical professionals also. So what should be the preparation towards for similar sort of things happening later? So what do you think from the AAAH Alliance and the work what you're doing? How do you envisage, and what is your take on that?
Okay, first of all, I would like to introduce that our this year, the AAAH conference will be focused on the building resilient health workforce in response to public health emergency, which is really relevant to the theme of today. So then we come up with the 3 critical points for making a resilient health workforce, which is easy to remember, is with the letter RED or RAID. Yeah, so R is stand for resource. what is critical is that we want resource to mobilize adequately and sustainably is really a must. Thailand has made millions of efforts to ensure geographical distribution of village health volunteer, the CDCU, as I mentioned, district and sub-district hospital. This is really the thing that Thailand really put a hard effort. And this is the fundamental of the 100% of, almost 100% of universal health coverage that Thailand have achieved. But it's also making it easier when the crisis hits one part of the country, and the rest affected area can be mobilized to support the other part. I remember when I was in the field of the big massive first wave of COVID-19 in Samut Sakhon among migrant workers in Thailand. At that time, I was there as a national team to support the regional team, assisting in the surveillance system and risk assessment. As soon as we realized that the risk, these threats, is uncontrolled, we set up the emergency operation center and activated a call for the other provincial team. They soon arrived within a week, and they not only come from just preventive team, but also they come with the care team to set up the field hospital. And this situation happened many times before. For example, like when tsunami hits Phuket and when the big flood in Bangkok. So this is a very good thing, and I think it's really necessary. The other thing is the letter, the second letter is E. E stands for essential public health skill for all. In the resource strain and workforce shortage, investing effectively is what we are looking for. Just like Dr. Sobel mentioned before, that it is impossible to build competency that's fit to every single threat. So what we need to do is that we need to identify what's really an essential and should be the fundamental of the threat, of all threat that we need to build up in our health workforce. And when it's come to threat to the population, yes, we need to think about investing in primary health care, not to over-specialize, we need to invest in general things. And just like the example of CDCU, they all equipped with the essential skills. So we need to make sure that everyone have the skill. For example, like the ability to do a risk assessment should be done locally, so that they will know when they need help from the outside. Okay, so the last letter that I want to mention is D. Can anyone guess what is D stand for? We mentioned a lot about this. So D, for me, also stand for digital technology, but this time in the aspect of health workforce. This is very important to integrate digital technology, because by using the mobile phone and telemedicine, we can make not only make healthcare equitable for the population, but it's also promote the well-being of the health workforce. You know, by minimize their workloads, by allow them to work at home remotely, also like minimize burnout. This is the tools that I think we need to focus on. So, and now, you know, Thailand now have digital national surveillance system. We now have that. So for the next pandemic, we can be sure that we will have real-time monitoring dashboard, and we don't need to spend forever for data collecting and data cleaning anymore. So this is the thing that's a good thing that we continue developing following COVID-19 pandemic. So another thing is that I think is really needed is the leveraging the digital tools and platform for tracking the health workforce. This is really a must, because these days we need to not even just know that how many health workforce we have, but we need to know about the competencies that they have. So by doing this, it will be allowing us to be able to manage workforce effectively and easily to mobilize anytime. So this is the really needs for the country for prepare for the next emergency. So in sum up, just prioritize rate, RED, resource, essential public health for all, and digital technology would really help me to be ready for the next shock. Yeah, and this is all from me.
Just a question, Dr.
Okay.
Choiswise to lead. Is it under preparation, or it's you're prepared with this based on the alliance work, what you're doing for preparing for staff shortages, what you have mentioned? Is it underway, or some of things are already in place?
Okay, so we, in response to the workforce shortage in Thailand, we have done a lot in the retention policy. I think the famous one, I think everyone, do you know about CPERT? The program that we, the local training, local recruitment, local training, and hometown placement. So we do this for a decade, like 2 or 3 decades already. And this is very effective policies that we retain them. And as we know that Thailand have very limited issue about the international migration, because we not only like doing like local training, but we also promote the better work environment and so on. So this make it easier for Thailand to make sure that we have enough supply for.
Means from the alliance, are you trying to scale these learnings to other countries, which are they part of the alliance?
Yeah, sure. Lab. As Asia, GLC4HSR's is a very good platform for sharing this. And as we focus on the action alliance, so we need to make action happen in the network.
Okay, thank you. Now, over to Vikas. Because what we have seen in the COVID, obviously, as what Dr. Chavis also mentioned, is the real-time tracking of data or monitoring of our capacities, right? Whether in terms of infra, manpower, so on. What has been your learnings and what you see? An appropriate response we need to be prepared for any public health emergency. Over to you.
Thanks, Girish. I think the monitoring is very important. Real-time monitoring of data, and in order to plan for health emergencies, which is often unplanned, is very important and key. I think, COVID-19 has given us lots of lessons regarding that, and there has been lots of effort to strengthen public health system in order to be more responsive to any possible pandemic in future. While those efforts are very important and well acknowledged, I think the real-time monitoring is very, very critical and important. Although in a resource-constrained settings like ours, often the monitoring, and especially the monitoring of key indicators like infrastructure and preparedness, get a backseat because there are many competing priorities, and in peacetime, when there is no kind of danger or no threat of a pandemic looming at our head, such real-time monitoring get a lower priority from health managers and systems. While that is the situation, but I would like to reiterate the importance of real-time monitoring and for health system preparedness and utilization. Once it helps us ensure better preparedness for any possible future emergencies like COVID-19 or any other pandemic, or not only pandemic, but maybe some man-made disaster or something like that. It helps health system to be more resilient and adequately respond to any such future emergency. And it also helps in timely response, because we can analyze the trend, we can analyze the surge very early on, and health system can adapt accordingly to response better. And it is also helpful to optimize resource in a resource-constrained setting, especially settings like ours in India. So So although monitoring real-time indicators for health system preparedness get backseat amidst multiple priorities, it should be prioritized, and despite being appearing to be a bit expensive. More importantly, it also helps us, in moving to the buzzword of data-driven decision making, which has always been a dream, but has not been that commonly practiced amidst multiple priorities and many competing priorities and issues. And it all not only helps from policymakers' perspective or health managers' perspective, it is also important for health systems functionaries and the beneficiaries of health systems. Because if we monitor the situation effectively, then we can also plan to communicate with the larger, community, if such threat arise, or if there is a situation when such possible threat is, is envisaged. In such scenario, the communication can very well be given to the larger population about the capacities and what they need to do in order to avoid, more, I'll say, kind of crowding at the health systems and every other thing. It also helps in continuous quality monitoring and other issues. And while preparing for this panel, I was reviewing some of the documents, and I think WHO, the World Health Organization, has come up with health system resilience indicators with very focused and key indicators, which is very important, very critical, and that can be worked out. Coming back to our experience from Chhattisgarh state, I think Chhattisgarh responded to COVID-19 quite well, and everyone from the community health worker at village level to the primary healthcare provider, the lowest cadre of primary healthcare provider, to the secondary care providers and tertiary care providers, they responded. But that was one of the situations where people, where the systems and the health workforce within the system stressed themselves to sponsor once in a kind of lifetime emergency. But it also took toll on probably the kind of continuation of routine services in health system. So, and one of the key outcome out of learning generated and probably the policy decision, which is pan India, for after the COVID, is that the mandate to develop block public health units, which is a block in India is generally for 80,000 to 200,000. It depends on the context, states and district, but largely, is in this range. And there is an effort to develop a block public health unit, which will have a block public, very state-of-art laboratory for point-of-care testing, then public health facility to provide clinical care, and most importantly, monitoring the health management information system and real-time monitoring of the preparedness. While the work on block public health laboratories is going on, I'm not sure a similar emphasis is being given on real-time monitoring. And, with this forum and collaboratives and the PHC forum, which the honorable keynote speaker highlighted today morning, I think we should continue to advocate for introducing such real-time monitoring for better preparedness.
Yeah.
Thank you.
Yeah, thank you, Vikas. Now I'll move to Dr. Ranasinghe, taking the country experience from Sri Lanka, what you have done during COVID and later. So how did you see the similar sort of, from a country perspective, on the real-time understanding the scenario, whether in terms of infra, manpower, or your experience? How did you do it, and what's been your learning to implementation now, post-COVID? Can you share your experiences?
Yes, I'll first brief about what we have done during the COVID. So we have two main areas, like we have the central government and the provincial. So under central government are the major hospital, the provincial government a lot of the other hospitals are there, especially the primary care services. And also we divide into the curative and preventive sector. So we had namely 3 waves. The first wave, we had less number of patients with severely affected. And the second wave, there was a huge number of patients. And third wave, exceeding the second wave also, the patients were there. So based on that, the first, when it come to capacity, so it's a clear planning. So, and we look into the other countries, what they have done and what are the mistakes they have done. So in the first wave, we have identified in 3 layers, like patients with severely affected who need ICU care, then the high dependency units, and also the patient with mild symptomatics. So based on in the first wave, we arrange several hospitals, around 15. And for the critical care, we arranged separate ICU hospitals dedicated for ventilation patients and critical patients. For HDU oxygen dependent patients, again we have identified. These are located in geographical areas. So in the second wave, so the patients are huge. So then we have to utilize our the secondary care hospitals were filling up. So we wanted to maintain the normal services. Then we have to go to the primary care settings, like primary care hospitals. So we made them as intermediate care centers. Even some kind of health facilities which looked after by doctors, we took into intermediate care centers. But in the third wave, it is the patient number was very large, and we have our system was collapsing, and sometimes we were unable to maintain the normal services. So what we done is then we have to take another initiative. We have to go for the home-based care. So we have triaged the patients at the hospital, and then we categorize in them to different levels. We admit the severe cases to our hospitals, and the moderate patients to the intermediate care centers, as well as the severe patients to the mild patient, which was managed at the home-based care. So that is a good concept. Now we are thinking, because the patients were sent back to home, and they were looked after by consultants through telemedicine method. And when it's come to we prioritize what are the areas we need to supply, and also we maintain the supplies. And we were initially lack of PPEs. So then we depended on the importing of the mask. But later stage, some of the private sector companies came, and they were making PP local production. So we have used that, and even these were imported to other countries. Sorry, exported to other countries. And for the HR, we did rest and rotation policy. Those who engage with the patients, we give some rest. And also we given social welfare activities, like giving transport and giving accommodation before they go into home, because we were keeping them for 2 weeks and then let them go to the home. And also we did the service in person training, as well as online training on handling patients, and also usage of PP. So, and also the oxygen was, the critical part was oxygen. Then we expanded the oxygen plants throughout the country. So those are the critical things. Lab facilities, again, we have only less PCR now, PCR machines. Then over the time, we have increased the testing capacity all around the country. So it was very fastly done. And also the supplies, we have a medical supply division which supplies drugs as well as the reagents for testing. So we were able to have the continuous supply of things. And for the finance, we had a separate COVID fund, which is dedicated for COVID. And for the IT, we have developed a surveillance system as well as a monitoring system, how many patients are infected, what are the deaths. So that is done in a dashboard. So those are the things that we have done, and some good things we are now going to adopt.
Thank you, Dr. Ransinghe. Over to you, Sanjay, just to understand from your end, and which is very critical part of the service delivery. One is that how do you look at the diagnostic capacities challenged and how you're looking it could be built up? And the other thing is different countries had issues, but how do you see private sector engagement as part of diagnostics as an area?
I think maybe I'll start with the private sector. I think there were some previous panels also which discussed, how critical it is to involve the private sector. And indeed, private sector is a key player when it comes to, access for health and specifically access to diagnostics. And it is therefore critical to have strategies and mechanisms to ensure that we are able to involve the private sector effectively during public health emergencies. The reason for this is that, there are large swaths of populations which are actually accessing care in the private sector in several low and middle income countries where the public sector is constrained to deliver care. And if you look at countries like India, Indonesia, and Philippines, almost 40 to 70% of the population is actually accessing care in the private sector. And now pivoting to the COVID-19 pandemic, we know, when the pandemic started, taking the case of India, there were initially very few labs which were able to sort of offer COVID-19 testing, but very quickly the government was able to scale up the capacity as far as the public sector is concerned. But the government also realized very early on that public sector capacity is not going to be sufficient, because I think it was becoming increasingly difficult to sort of establish public sector laboratories, and specifically since the initial dependence was on PCR testing, when we are looking at districts and rural sites and all of that, it was becoming increasingly difficult for the government to sort of provide the relevant coverage as far as diagnostics is concerned. And that is when very early on there was this decision by the government where ICMR and DST and a lot of the other agencies were also involved, that why not also involve the private sector. And if you look at it, out of eventually the 3,000 odd labs which were established in the country, which were offering COVID-19 testing, nearly 56 to 57% of these labs were in fact in the private sector. And so this is a key example where the private sector, it worked hand in hand with the public sector to ensure that not only are they providing access to testing, but this access to testing was also provided at subsidized cost, so that people from all echelons of the society could actually access testing in the private sector. Then on the other hand, and the other piece that was being ensured is that there were only a certain kind of kits and a certain quality of test kits which every lab in the country was doing, and this is also true for the private sector. Private sector was also enabled to do necessary data reporting into the central database, so that the government was able to publish the results in terms of the number of patients who were being tested on an everyday basis. So while this is one example from India, another example is from South Africa. Now South Africa, some of you may know that it has a very centralized system of diagnostic services which is managed by their National Health Laboratory Services. And they were also, like a lot of the other countries, they were grappling with this, and this is a very efficient system, but unfortunately, as I said, it is a very centralized system. The samples are collected from various provinces and districts, and they're sent to some key laboratories for testing, and this unfortunately was not sufficient to provide the required coverage. So they also engage very effectively with the private sector. And in fact, it is of note to say that the number of tests conducted in the private sector in South Africa far exceeded the number of tests that have been conducted in the public sector. So while it is clear that, and then there are several other examples from other diseases like tuberculosis, where I think the governments have been effectively leveraging the capabilities and capacities of the diagnostic of the private sector. I think even during the COVID-19 pandemic, the private sector was very effectively involved to enhance the vaccination coverage, and we know that almost every private hospital in the country was sort of provided the necessary guidance and the infrastructure to be able to accord necessary care to the patients. Coming to the second question on diagnostic capacities, I think I would probably split this into two. One is that how do you develop capacity within the countries, and the second is that how do you ensure the utilization of the installed diagnostic capacity. So the other thing which we saw during the pandemic was that there was this extreme fragility of the supply chains. And the reason being, and again, talking from the diagnostics perspective, the reason being that countries across the world, be it high-income countries or low-income or low and middle-income countries, they were dependent on a very limited set of manufacturers for their diagnostic needs. There were only a handful of companies which were supplying, these PCR tests, and hence it became very critical for the countries to look inward. India, for example, there was this INDX 1.0, which was established in collaboration between the Ministry of Health and the Principal Scientific Advisor's Office, where there was a specific effort to indigenize the manufacturing of PCR test kits as well as rapid antigen tests, as we call the RATs, which contributed in a big way towards overcoming this high dependence on some of the global suppliers of PCR test kits as well as the antigen tests. So I think there's an important lesson here for the countries to learn, that it is extremely important to develop internal capabilities for innovation, research and development, and more importantly, manufacturing, so that you're not only able to meet the local needs, but are also able to sort of, be a regional player and are able to support the countries in God forbidding there's another public health emergency. And this is something which has also resonated through the presidencies of India, Indonesia and Brazil, the G20 presidencies, where there is a lot of focus on establishing these regional manufacturing hubs. The second aspect of diagnostic capacity is around how do you ensure that you utilize the installed diagnostic capacity. In India, for example, we know that there were almost 6,000 to 7,000 PCR machines which were available as part of the National TB program and the National AIDS Control program. So the government very effectively leveraged, and these machines are actually are installed at the district hospital. They are near point of care machines. And there were mechanisms which were put into place to ensure that these machines are being leveraged for testing people for COVID-19. But now that we are, past the pandemic, and countries, in fact, have a glut of diagnostic infrastructure, which they're now finding it very hard to use, it is very important to have integrated diagnostic strategies to ensure that, that programs do not act in a siloed manner. For example, if it's a machine which is bought by the TB program, it should not necessarily be treated as a TB machine or an HIV machine. It is very important that, and all of these platforms are in fact multiplex systems, which means that you can test multiple pathogens on one platform, which means that, if there is one PCR machine lying in one district hospital, it can be leveraged by an HIV program or HCV program or a TB program and be used for all of the other, all of the other programs as well. And last but not the least, we also saw during the pandemic that, there were also constraints in terms of the workforce, laboratory workforce. And I know my fellow panelists, she spoke about how important it is to build human capacity. And hence it is, very critical for the country to ensure mechanisms that we are, training the laboratory workforce not only in basic testing, but also in testing and using advanced molecular diagnostic equipment, so that they are able, they can be pressed into service if the needs arise going forward.
Thanks, Sanjay. Over to Dia. Yeah, Dia, we just want to look at your experiences from Indonesia and the initiative what you're doing on the COVID and as well as in the primary healthcare. We want to learn your work and the progress in that.
Okay, thank you. I think listening very closely to colleagues here on stage, I think the one difference perhaps that we have to start from is that actually health system strengthening effort at primary healthcare level or at other levels are not detached from pandemic response, from health emergency response. That it's actually embedded all along when a country talk about health system strengthening, it actually also inevitably have to strengthen emergency response actions. Unfortunately, that realization came too late after all the impacts of COVID. And we only learn after that actually integrating health system strengthening approach and pandemic response is what we should have done all along. We didn't know this as well when we as in CHISD started our pandemic response efforts. We started way before the pandemic, which was 12 years ago, with a program designed to strengthen primary healthcare. At that time, we didn't realize that it is actually very close, or it's very closely aligned with what we should do for COVID response and also pandemic mitigation, and also for community resilience. So when we talk now about pandemic preparedness and response and community resilience, we are actually talking about investing more in health system, from health workforce, from diagnostic and laboratory capacities, from innovative financing, and that is what we do in approaching the situation where we see primary healthcare as the ground zero, so to speak. So it's an ecosystem where we intervene, or we put program in to strengthen primary healthcare centers, but also at the same time strengthening communities. In Indonesia, we have that separated or in two levels, in two different levels. One is in puskesmas level or primary healthcare centers, and the other one is the community-based efforts for health, where the post is called posyandu, where health workforce man or live in the primary healthcare centers, the community health workers live in the posyandu. And unless we combine and integrate programs or interventions at both levels, we will not and cannot ever achieve community resilience. So it cannot be done separately. It has to be approached in an integrated and comprehensive manner. And that's essentially what we are doing. During pandemic response period, we send teams to 100 primary healthcare centers in West Java province. That is with an outreach of about 8.5 to 10 million people, more or less, roughly. And then when the response period is over, we intervene and focus our intervention at community level in our posyandu. So now we have a future, or the potential or the DNA of a future strengthened primary healthcare system in Indonesia. What we would like to see to build community resilience and also to build preparedness. Interventions cuts across increasing capacity at primary healthcare centers and also increasing capacity of community health workers, getting or obtaining community-based data in our dashboard. So we have employ digital technology, enable screening tools for community health workers, train them. We also start to dabble in how to have a better outreach for vaccination coverage that is forward thinking right after COVID. Also, like Jack highlighted earlier, we put this policy, put out this research and various research and put out numerous policy recommendations to government pertaining financing, health financing, also in tobacco control and also in food policy. If we put excise tax in tobacco control and food, sugar sweetened beverage, then it will provide the government with fresh money, which we hope can be invested into health system. So it becomes full circle. We do not stop at just having programs on communities, but we bring the results and the evidence and the findings to the government for which they build and base their policies on.
Thank you, Dia. Just a follow-up question was that in your initiative, currently, are you able to see real-time data?
Yes, we do.
Which areas you're able to?
So we are in West Java. We started from 100 puskesmas in the province, and West Java is the largest or the most densely populated province in Indonesia. It consists of 20% of the whole population of Indonesia. And then we focus on 3 different cities and regions, and now we are in 2. So we are developing and re-enhancing the model so that it can actually be used for policies by government. And I saw in Manoj's slides about the 6 transformative pillars that Indonesian Ministry of Health put out. That was actually enrolled or implemented right after our CISD's initiative in primary healthcare center in West Java started. So I think we complement the government in this case, and we work very closely to be able to present them with the necessary data and findings.
Okay, thank you. Since I think we had this round of discussions which is happening, but I think few areas which are more dimensionally more important to discuss as we are seeing one is obviously we are talking of real-time capacities, right? So since we have the panel, I will also ask Sanjay how you see real-time capacities from your end, whether it's diagnostics or from a health systems perspective based on the experience. How is the movement towards that? Still it is manual, it is moved into a certain direction.
So I think just maybe to clarify, it's from a data standpoint or?
Yeah, data from administration, from a management point of view, how do you access data to make interventions? So COVID, it was not visible at a given point of time.
So I think as has been also addressed in the previous panels and was also being articulated now, that it is very critical to have access to data. There were some great examples, for instance, during the COVID-19 pandemic, where it was, the way the government was sort of sharing information in terms of the number of tests that were being performed on a regular basis, or the number of people who were being vaccinated, number of people, who were occupying the hospital beds. I think that was and also, in terms of, putting information on a regular basis in terms of the number of labs that are available for diagnostic testing. I think this was particularly more, relevant when we were talking about vaccination, when you had to vaccinate millions of people, for example, in countries. And it was particularly hard for people to see that how and where they can access, these vaccination services, which is when we all remember we went on that CoWIN platform, which was established in India, and we were able to sort of, reserve our appointments and, so I mean, there was a lot of real-time data sharing that was happening. But, oftentimes what happens is that, the governments as well as, a lot of the organizations which work very closely with the government, they are essentially privy to a lot of health information and a lot of health data, which, you know, doesn't necessarily become available at the right time. I mean, there are learnings from the COVID-19 pandemic which really showed us the value of how critical it is to be able to share data in real time to sort of enable data-driven decision making. I mean, if you look at, you know, TB, or if you look at malaria, you know, we are now talking about how you can leverage AI and ML in terms of enabling decision making, you know, doing predictive analytics to sort of, you know, predict pandemics or predict epidemics. But, you know, all of this will sort of remain a pipe dream till the time, you know, the data are made available in a more safe and secure manner. You know, also at the same time, it is critical to be able to protect individuals so that there is no leakage of, you know, personal information when you're, you know, sharing this data is concerned. So I think from a data standpoint, obviously, you know, we are pretty clear in terms of how we need to go forward, how we need to think, you know, how we need to sort of develop capabilities to analyze the data that is being made available, and more importantly, how can this data be shared, you know, across the countries and across the geographies. I mean, this was again something which was a classic example during the pandemic, but probably doesn't happen all the time. I think it is very difficult for, you know, and countries are not really confident in terms of sharing the data more globally. A lot of times it also goes towards saying that if there are an X number of cases, for example, let's say tuberculosis, you know, in a certain country, you know, the perception of that country, this is a high TB burden country, you know, and those perceptions also need to be managed, you know, which will develop the confidence and the ability within the countries to be able to share their data more importantly. And once this is developed, then we need to have mechanisms in place, you know, which will enable this data sharing on a more regular basis. I think another classical example was, you know, there was a lot of this tracking of sequencing variants which was happening during the course of the pandemic. There was this data repository known as GISAID, which was established, which sort of enabled all the countries to put in information about their sequencing data in an anonymized manner. So I think these are some clear examples, you know, use cases that have been established during the pandemic that I think should be advanced and should be leveraged going forward to make sure that data sharing and, you know, data acceptance is sort of made possible going forward.
Chief sir, this related question to the workforce. So when you spoke about the digital area, so if you have to do the preparedness from rapid skilling and to be prepared, right? So from digital and skilling, which areas you found can be done or you're looking at to make it happen as part of the alliance? Which focus, what are your focus areas?
Okay, for sure, in terms of health workforce, ability to manage is really important. Yeah, I mentioned earlier that the good human resource information system, which is integrate, that can trust not only the numbers, because now it's really necessary to know the capacity. And I know from our colleagues that, you know, like the competency-based training, for example, like CPD that in Sri Lanka is doing, or the performance in the primary healthcare in Indonesia, they all need to have a platform to register that these specific health workforce has already upgraded themselves to be able to have this competency to work, to be ready for the next trust. So I think the most important is the good in digital information system about human resource for health, which can be created in every aspect. Also, in response to international migration as well, if we can collaborate between countries to share the data, and it's very good to plan.
Because based on a similar sort of thing from the skilling point of view and community engagements, how do you see the capacity building or the skilling for preparedness? How do you see from the your experiences in the field? We are unable to hear, Vikas. No. Unable to hear. Maybe Dr. Ransingh, you want to give your comment?
Regarding the service delivery.
About skilling of people to be prepared for the any sort of public health emergencies. Your take, how you are doing in the Sri Lanka in your work?
Yes, several strategies we have developed. Like now, the last we have done the JE evaluation. So there are weak points that we have come across. So especially the surge strategies for the public health emergencies, we are going to make a plan, and also we incorporate not only health, the other sectors in a one health approach. So other thing is we want to introduce telemedicine especially, and we have started the pilot in one district where the emergency physicians look after by the primary care settings, and he also involved in personal seeing as well as mentoring to telemedicine as well as seeing the patient's conditions. So thereby we giving the consultant service to the primary care level, as well as he has developed capacity building programs for basic life support, advanced life support, and management of MI patients, and also giving the, as Dr. Reddy is expert on cardiology, so we wanted to have the thrombolysis at the primary care level through the telemedicine guidance. So those are the plans we are doing, and also we have pilot this in one district, but we want to replicate in other 26 districts. So, and also we want to see the distribution plan of HR, and there should be a fair distribution. So, and also think about what are the lacking cadres and improve it. Those are the things that we are planning.
Thank you. Over to Vikas, you want to?
Yeah.
Yeah.
Can you hear me now?
Yeah, we can.
Yeah, thank you. The discussion we are having till now on especially, I think three parts are important. One
We are losing your voice. We are unable to hear.
I missed one point regarding the HR. We wanted to go for community engagement. So we have launched a program, a caregiver program, especially for the community who look after the parents by their sons or daughters or the bystanders to give them training, especially debilitated patient, geriatric patient, and also cancer patient. So we want to go to community. And also there's another program for A&E. The College of the anesthesiologist has come into front and train the community people to attend the emergencies.
Okay, thank you. Yeah, over to Vikas. No, we are not able to hear. We'll come back to you again. We'll come back. Specifically to community engagement in your transformation work, what you're doing. So if we need to link to the preparedness and resilience, I think what could be the key things you want to suggest or to be looked at?
I would suggest that we ask and be critical to ourselves of relevance in the future. I think it's a question that we have to ask continuously and concretely at our intervention. We set a forward-looking mechanism where we see health cadres as a proxy of the health workforce, and that they should be enabled and in full capacity to do their task, which is mainly screening. And it should be easy for them to do. It's not difficult, and they achieve the level of competence that is stipulated in the government regulation. And so I think it is a forward-looking step. And that is why we gather the community-based data, because in the future, community-based data should be the source of data that we go to, because pandemic response is solved at community level, and data should be available at community level. And if you are asking about resilience in communities, then we cannot achieve resilience if data is somewhere very far, that it's not readily available to policymakers at subnational level, at primary healthcare centers, and even in communities.
Thank you, Dia. Vikas, one more attempt. I think you're not able to. Can you try once again? Again, we'll try and come back to Vikas. I think there's something. You can hear us? Okay, it's the other side. We are not unable to hear you. We'll come back to you again. Okay. Since we are now last 20 minutes of this session and wanted, like, from our last 2 days is to have more questions from the audience and from thing, I'll open the floor for questions to the panel. So I think over to the audience.
I have a question here, and I also have the mic, so I'm going to go first. This is to Mr. Samantha, Dr. Samantha. I'm curious to understand, given that Sri Lanka has seen multiple threats like conflict, the pandemic, and then economic crisis, especially the pandemic on the tail end, followed by the economic crisis. When you look at that, what do you see as differences in the challenges that come from these different threats? And how difficult is it then to plan when you have multiple threats coming together? Thank you.
Yes, Sri Lanka going through rough periods, and it's normally they said a resilient health system. Now we had tsunami also, we recovered, and also we had conflicts. So we recovered from health sector per se. So it's a clear planning and also the governance and on how our system is structured. And lastly, we had an economic crisis. So anyway, we have utilized the HR and other activities with the given limited resources. I think we have efficient system. So we are managing per capita health expenditure around $100. So as for your question, I see it's a structure that has given the resilience. So even now there's a dual practice for the government sector as well as the private sector. So they can do the both activities, and private sector also give a good support. And one thing is we have forgot is the indigenous medicine. Some population around 30% they go for the indigenous medicine. So we haven't taken account into that. So all this the health system has contributed to absorb these shocks. So I think I have given the answers, and currently we are facing the HR issues, the migrating. So we have backup plans. We have universities now, and also wanted to produce more healthcare staff. Ministry of Health is producing their allied health professionals by themselves, except doctors and dental surgeons. Others are produced by the Ministry of Health. So we have a capacity to increase the number. And now currently the universities producing a lot of doctors, and now our card is filled. So now we are in excess. But the consultants also, the problem is the consultants, the specialists. But again, there is a mechanism like resource sharing. Example, I said the telemedicine will be implemented, and also we were thinking about increasing the specialist cadre. and production. I hope you are good.
Thank you, Dr. Samantha. Thank you.
I had a question for Dr. Saran. The story of the mobilization of the private sector in India and South Africa generates the question of sustainability. Is this something that those two countries, prominent in BRICS, intend to sustain? Will there be some sort of continuation for chronic challenges like malaria and others, not so much South Africa, but in India? What is the future of this? Is it just going to all dissipate?
Yeah, I think good question. So just to say, I think it was, I mean, and again, taking the example of India, the involvement of private sector, in the COVID-19 pandemic was not really a one-off. I think there has been a history of a very rich private sector engagement in the private sector. And, one of the classical and you have one very big one by the central government, which is known as the CGHS, or the Central Government Health Scheme. So, the beneficiaries of these health schemes, they're not only able to access services in the public sector, but the government has also impaneled a lot of top hospitals, and these hospitals are across levels. From level 3, upwards to super specialty hospitals, and with the intention that the beneficiaries of these schemes can access services at the private sector. The rates, etc., have also been pre-negotiated. Although there is a constant tussle between the private and the public sector, where the private sector always feels that the rates that the government is paying are always on a lower side. But having said that, the government also promises this very huge prospect of large volumes of patients. I know that personally because, my parents, they are retirees from the central government, and they have been able to benefit these services. And this is something which is really huge. And, from a simple, blood test to getting a total knee replacement or to a CABG, you're actually able to access these services at pretty affordable costs. And it is not that the beneficiary has to pay. Those services are paid for, by the government. But this is again, for a very select group of people who are sort of, beneficiaries of the central and the state governments. I think there is still a lot of work that needs to be done to sort of involve to bring down the prices or sort of rationalize the access to healthcare within the private sector in countries like India, because I think in some ways access to top care health, in countries like India is still out of the reach of very large percentages of population. I think this is particularly challenging because the coverage of insurance of any form, there are less than 25% of the Indian population which is covered by health insurance. So I think it is sort of a multi-pronged strategy that the countries need to look at. There is obviously a lot of merit, and there is a lot of capacity and expertise which is available in the private sector. There are enough and more examples, but as you rightly say, I think there is more that needs to be done. Private sector is willing and able, and you need to really involve the private sector in decision making. Oftentimes, they feel that the decisions are made by the government, and the private sector is supposed to simply enforce or enable those decisions. So I think there are multiple aspects, but I think there is a real scope of sort of making sure that these efforts can be sustained on a long-term basis.
Go to Doctor.
Yeah, this is one question related to the provider system resilience point of view. Given the mixed systems, the private and public, and also given the fact that you cannot create surplus capacity in preparation, because then the efficiency and the cost, you need to handle that. In which case, the pooling that was done during the COVID, but in terms of the preparedness, yesterday, the Indonesia presented their evolving national digital health mission in terms of national registers of the facilities, of the workforce, of the diagnostics. I mean, India is doing the same thing, HPR, HFR, the Health Professional Register and Health Facility Register. And what Joe has also mentioned in terms of it's not only just the professional register that the country should have, but also their capacities, their competencies, the mapping of these things. What entails is that if you have this basic data, your ability to understand where there is surplus capacity and where there is excess demand, how do you relocate? So this is one aspect I think Girish was alluding to in his questioning also in terms of the real-time data on provider capacity, in terms of infrastructure capacity, in terms of the human resource capacity. So that is, I think, one element based on the experience during the COVID can be integrated as a part of a resilient provider health system. So I think that's one takeaway that was coming out that the countries can invest in having this real time, just like the disease surveillance, it is surveillance of your capacity, whether it's adequate or not adequate. The second challenge that we faced during the COVID is when we were attempting to pool and partner with private sector, there were no prior agreements in terms of what should be the terms of engagement when there is a public health emergency and you need to basically nationalize the private provider system. If there is a prior agreement with the private providers, just like we have as a payer system, PMJ or public health insurance systems have a agreement, right, engagement agreement. If there is a prior agreement that if there is a need during a public health emergency, and these are the terms applicable for us to pool both public infrastructure as well as private infrastructure. So these are the two elements, in fact, as a part of resilience assessment of the provider system. We were including these as indicators, whether there is a real-time capacity monitoring system, and also is there a prior agreement with the private sector in terms of pooling resources when there is a need. These were, I mean, these are more as a comment rather than as a question with reference to what are the other characteristics? I mean, because what Dia also mentioned in terms of, yesterday also there was significant discussion in terms of the community engagement, but how do we institutionalize those better practices which proved to be very effective during the COVID as a new normal? Because we, again, otherwise we will be only responding in ad hoc fashion in the future if it is not institutionalized. We talk engagement, but how do we institutionalize community? How do we institutionalize the private sector? I mean, these are the two things are mentioned as a part of stewardship, but there are no processes, defined process, institutional processes define that. So if you put those institutional mechanisms, they constitute a component of resilience health systems.
Perhaps I can respond to your comment, Dr. Reddy. We have yet to find out whether this strategy works or not. Under the 6 transformative pillars of the health sector, there is a plan to constitute a reserve workforce, reserve health workforce. We are still waiting to see how the norms and guidelines will look like to build that, but at least it's there. That's one. In the national regulation, in the transformative pillar, as well as in the new constitute health law. Also in the health law is the first step towards institutionalizing community health workers or health cadres. Of course, it's still a long road ahead, but at least the first goalpost is there, and it creates space for institutions like CHISD to do our intervention based on that. So there is the plan, there is the vision from the government. What do we have to, how do we fill the space? How can we actually achieve that? So those two areas in the primary healthcare level, in the ecosystem of primary healthcare. In In the hospital setting, secondary care, the government is now doing a hospital-based education for specialized medical doctors. Again, that is still a very long road ahead because it needs to, workforce need to be divided, the teachers, the professors need to be ensured, and quality needs to be guaranteed. But the first step towards fulfillment of capacity needs of health workforce in Indonesia is there, with the hope that when the next pandemic starts, there is the reserve, we have more specialized medical doctors, and we have higher capacity community health workforce. And also, I think, again, Jack put in word about Indonesia's step in multilateralism, where we invest, or we put in an early starter to Global Fund, and also an early starter to the Pandemic Fund, where we are still trying to get communities to work together, and then it all, I hope, it all becomes a full circle in due time, and not too long from now.
Maybe just one more additional comment, Dr. Reddy. I think while she made important comments on the human resource capacities and reserves and mapping that, I think at FIND what we have been trying to do now for the last few years is supporting the countries in something known as a diagnostic network optimization exercise. So the goal here is, and this is again, Girish had raised a question around, diagnostic capacities as far as countries are concerned. So the goal here is, and somewhere to your question also, the goal here is that we are trying to map the available capacity within the countries as far as diagnostic testing is concerned. I think so far this has been relatively limited to TB and HIV. We are also working with Indonesia, where they've asked us to look at it across 14 diseases which they're trying to screen for at the Puskesmas level. So the idea here is that you map the technologies which are available, you map the capacities, you sort of see to what extent those machines are getting utilized, and are able to come up with what is the excess capacity that these machines have. And this obviously needs to be updated on a regular basis. So we are also working to establish something known as diagnostic accessibility dashboards, where you are able to monitor in real time that how are the patients able to access these services, diagnostic services, wherever they are available, so that countries at all times, when they're doing their procurement planning, or when they're looking for new technologies, this also sort of goes one level above, where we are able to advise the countries that, given that there is a higher disease prevalence of a certain kind in a particular geography, versus another one, but there is a mismatch in terms of the diagnostic capacity. We are able to advise that if they're either able to move the machine from one geography to another, or add capacity to this specific to the geography where the needs are more, how they will be able to increase access to testing. So that's another effort which we're trying to do, but more on the diagnostics.
Okay, Dr. Jhalani.
So I have one comment and a question. Just to add what really worked also, looking at the example from India, I think the way the data was shared and who shared the data made a lot of difference. The data was primarily shared by the leading scientists and those who knew their science, and rather than politicians or all types of sources. So I think this credible sources giving out data and on a real-time basis really made a lot of difference, even in addressing the kind of misconceptions that were going around. Just to sort of add, and my question is that what COVID response also revealed, especially in India, and maybe in other countries also, that urban health systems were not as robust as we always thought, and we thought that the rural system was the weakest. But it sort of exposed the fault lines in the urban health systems, especially from metro cities, because where the large informal settlements, large floating populations and so on. So it showed that this system also needs a lot of strengthening and a lot of supporting, and I don't know whether that lesson has been learned well enough, and what is the experience, if at all, from other countries. I think in India it was realized that the urban system also needs a lot more strengthening. Thank you.
Manoj, you want somebody to answer, or it's a comment?
May not be answered, but I'm just saying that, were there lessons learned about, the urban, because this is that, we want to just have things moving to the rural areas, which is of course there, which is true. But COVID showed that urban system was no, better or best. That also needed a lot of support. And there were many things which were lacking in our, urban systems also. So that was, I think, a lesson learned from COVID.
I can share the lesson from Thailand during the peak of the case during the COVID. In the urban area, it's like a mess because in Bangkok, we have a population density is really a lot comparing to the rurals. But luckily, at that time, we can explore like new player to fill the gap of the health system, which is the private sector. It's not only the private hospital, but we can find like volunteering, like many organizations from non-health that support us in refer people to the urbans. Also assisting in oxygen and medicine, essential medicine to home, like delivery to home. So then we address that. We can expand so many roles and many rooms. Like next time we can prepare for this task that, like we got so many players. And then we can explore capacity more. Like we also use the hotel to be the hospitals. We use a monk, like a temple for monk. Like we use that to be a hospital as well, to be a isolation place. We strengthen the factory to taking care of their workers by making it to be a isolation place. So the roles like that, the next time we can plan better to engage them at the beginning and find a platform to work collaborations and share the data together. So then next time we will be more ready. Yeah, this is the example. Yes, please.
We are running out of time, but please go ahead.
Perhaps to add a bit of reminder or context, I think we should have it clear in our minds as we move into preparedness and resilience from where we did the response period. I think inevitably during response period, private sector involvement are wide, and it's because of the nature of the emergency. But as we transition from response period into a question of preparedness and resilience, I think this is where government or policy need to be put in place based on the learnings we have during the response period. And that includes learnings from countries such as South Africa and India, and also I think Argentina. What do we want to avoid, and what space do we would like the private sector to fill? I think it's a question to policymakers more than it's a question for civil society organizations like CHISD or others, but I think it's a good thinking mechanism to have. I think it calls for a different approach and different thinking on policy as we talk about private sector involvement.
Over to you, Dr. Rakesh. You have a question. So this is the last question.
Yes. It was just a comment
Yes.
just to add, actually it was partly addressed also, key
what the example of a pandemic that we went through is something extraordinary. I don't think we can prepare particularly big cities. We can have capacity to build so much of a hospital, and then you need, and to maintain these things. I've seen how we were maintaining in Switzerland bunkers for a potential atom bomb and those things. Those are really waste exercises. So here I think we have to have a strategy where such crowding can be avoided. We have learned things, and that's what she was mentioning, that more of a teleconsultation and information of correct kind so that people don't have to rush. Those are the, we cannot be prepared that where half of the city is looking for a hospital. That is not. So we have to have different strategy. And of course, capacity need to be built, but not to the scale that we have seen. So that could have been avoided with other methods.
Yeah, thanks for the comment. I think we are running out of time. Request Shweta for the closing remarks. After that.
Good afternoon, everyone. As we move towards the end of the session, let me present to you some of the vital insights from this discussion. We began our session getting into the details of socio-economic impact of COVID on the global health, essential services, leading to poverty, education poverty, and climate threats. Investment in primary health care is fundamental to our response to public health emergencies, and also in our continuous mission towards universal health coverage and health system securities. Human resources for health continues to be the backbone of health systems at all levels. Mechanism of integration is very crucial. When I say integration, it is an integration of essential public health functions, quality, and essential digital interventions. Lab and diagnostics need focused efforts in terms of building the capacity, and also in developing new means to utilize the existing resources in the countries. Also, there needs to be clear strategies in terms of involvement of private sectors. Real-time monitoring is crucial in terms of both during the normal times and during emergencies, not only to ensure our preparedness, but also to enable better data decision making. Last, health emergency preparedness should be embedded in health system strengthening efforts and should not be attended in silos. From innovative strategies to real-world examples, I think we all have gained valuable insights from this session. Each of the panelists has brought to this table their unique experience, expertise, and viewpoints, which has not only enriched our vision, but have also broadened our understanding of the subject. I would like to extend my gratitude to all these distinguished panelists and would also extend a heartfelt thank you to our moderator for skillfully guiding the panel. A big thanks to the audience for their active participation and interaction. And as we depart from here in this session, I would request everyone to carry forward the insights gained, the connections made, and the dialogues initiated, and try to convert these into some meaningful action points. Thank you.